All right. Well, good afternoon, everyone. I guess afternoon if you're on the East Coast. Brandon Gare with the National Minority Equality Forum here for our usual Friday webinar. Where we try to just give you a little education about some things that are going on. This week, we are featuring our one and only Dr. in Training, Mia Keys, who will moderate a panel with Dr. Miranda Ward, who is a professor at George Washington University. I also want to highlight Mia again in that this is, I think last time we spoke to Mia, she was Chief of Staff to Congresswoman Kelly, and now she is Director of Federal Government Affairs of, if I say it wrong, correct me, Hologic? Hologic. So she has a more insight, but all in the healthcare space and all what willing and able and ready to help educate us. Dr. Ward, you'll hear more about her, but one of the things I know, she's a alumna of Spelman College. Is that correct? And she got her PhD at GW, EDD, sorry, excuse me, at GW as well. She's also one of our 2019 40 Under 40 honorees. And so with that, I'm just going to turn it over to the docs, and I'll be on and talk to you guys later.
It's always a pleasure to be here with the NMQF family, Brandon. I want to make sure that everyone can hear us. If you all cannot hear us in the audience, if someone can just put something in the chat. If you can hear us, give us a thumbs up. Perfect. Great. Fantastic. So as Brandon mentioned, I'm Mia Keys, and since the last time, or one of the last times I joined you all as moderator, I've since moved over to Hologic, so Women's Health and Innovation tech company. And so we're really excited to do the work that we do. Today, I'm even more excited to speak with Dr. Miranda Ward, who is going to talk to us about HIV, AIDS, and aging. And I will also say, in addition to having transitioned to a new position, I'm also a new mama who is on double duty today because Munchkin is home. So if you hear little pleasant sounds in the background, I promise I'm not making sounds with my mouth. There's a little person somewhere underneath my feet and underneath the table. But Dr. Ward, as Brandon mentioned, is assistant professor at GW. She's also the director of equity within the Department of Clinical Research and Leadership at the School of Medicine and Health Sciences. And in that role, she designs, she evaluates, and she teaches health equity curricula for undergraduate students. And she's able to integrate whatever her curricula are within her podcast. I encourage all of you to take a listen. It's called Equity Matters, or #Equity Matters. She's been recognized for her teaching excellence with the highest teaching honor that anyone can garner at GW, with the 2021 Morton A Teaching Award. And there goes my earring. And I'm going to turn it over to Dr. Ward to tell us a bit more about herself. And the little one also wants to say welcome, Dr. Ward.
Yes, well, thank you so much. I appreciate the resounding reception that I'm getting by your little one. So yes, I'm happy to be here. Let me just pull up my slides really quick, trying to multitask. Pull that on up. Okay, there it is, perfect. So I'm gonna make sure, can everyone see this?
We sure can.
Okay, perfect. Okay, just want to make sure there's no tech issues. All right, so happy Friday, everyone. Thank you so much for joining. First, actually, let me just thank Brandon Garrett for the invitation to talk today. I am incredibly excited. We were just, right before we all joined, we were talking about, the level of enthusiasm during this week's registration process, and the sheer number of folks who have registered and actually shared that, you know what, I'm living with HIV. I'm so excited that we're having this conversation, and I cannot wait for you to weigh in as comfortable when we get to the Q&A. So, I'm just really excited for what's in store today, and I'm sure you are too, Mia. So as was shared, my name is Miranda Ward, and I'm actually logging in from DC, the ancestral lands of the Nakashtuk tribe. And so, historians refer to this indigenous tribe as the Anacostans. So yes, I live in DC, I work in DC, I studied, like Brandon mentioned, in DC at GW once I, graduated from Tulane and Spelman. And so I am a transplant from California. But the thing is that I've been doing HIV prevention work for a while. So I was doing HIV prevention work at Children's National Hospital for 5 years and through my own youth nonprofit called Promising Futures for over 20 years. And in that same time, I've also engaged in HIV research. Yes, I'm a professor at the George Washington University who happens to also be a member of the DC CFAR Center for AIDS Research. And so I know the plan is for us to have an informal conversation after I have this, kind of more formal, kind of didactic portion. And that's going to include a Q&A. So as was said, please go ahead and just post your comments as you have them into the chat. If you do have questions, put them in the Q&A box. Because I really do also want to tell you about a research-informed educational model that I'm leading. But again, like I said, I want to just put some things into context as we commemorate National HIV/AIDS and Aging Awareness. So with that, let's just go ahead and get started. So it really is important for me to just be very clear that, today I'm going to be talking as someone who is not living with HIV. So I cannot offer the expertise that is lived experience, but what I can offer is expertise from studies and expertise from community engaged work. And so again, I want this to be conversational and I want to hear from your expertise for those of you who have different expertise than mine. And I look forward to learning from you as well. But speaking of the work that I do plan to share, the program that I'm going to talk about, the 2-in-1 HIV and COVID screening and testing model, it is funded by Gilead. And so that program is not actually going to be part of my formal presentation because I'm just going to bring it up when we get into the Q&A portion of today's webinar as an example of what you can do to actually combat HIV stigma. But I just want to be very clear and very transparent, right, around these disclosures, and know my work or this talk is not going to promote any particular HIV drugs. So the whole purpose of today's discussion is to recognize the ongoing, enduring impact of HIV stigma. And I'm hopeful that when we get to the Q&A, we can kind of just talk about like where that stigma even comes from. So basically, there's just so many different awareness campaigns, like the one that we're honoring today ahead of September 18th, which is the official day. But we also need to discuss how we can prevent stigma in hopes of eliminating it for everyone, regardless of their age, but especially for those who are older and living with HIV. So, can you even believe that 2022 it's almost come to a close? We literally have 4 months left. So just thinking of, basically what's left of 2022, we do have 4 national observances left. So I'm going to start with the one that we're probably all familiar with, especially if you do HIV work or if you're living with HIV, and that's the one that happens every December 1st, right? World AIDS Day. But the thing is that we also have, next month, what's called National Latinx AIDS Awareness Day. And I think that's just really important to bring that up, especially just yesterday was Hispanic Heritage Awareness Day. But as you can see, this month, we actually have 2 observances, one for gay men, and then the one that we're focusing on today, which is on aging. So did you know, that basically, according to most recently available data from the CDC, there are an estimated 1.2 million people that are actually living with HIV. And so let's get into some of those specifics, okay? So of those with HIV, I really want to just kind of zoom in specifically to the new cases that we've seen over time, right? So to be very clear, we do, as the US, we have a national HIV plan. We call that, ending the HIV epidemic. And that literally talks about where we are, but where we hope to be with the benchmarks. And so the plan is to significantly reduce the number of new cases every year. And this is where we, hope to be by 2030. And then we're just projecting where we are so far. And as you can see on, with this graph alone, we've only more recently seen a larger decline in the number of new cases each year. But if we take a closer look, though, at the decline overall, we see that it's not the same, for age-specific subgroups, right? So like the number of new cases is not evenly distributed across each age group. It's actually highest amongst those ages 25 to 29. And for 3 subgroups, it's actually increasing, as you can see here, right? Ages 13 to 24, and then the 2 groups between the ages of 35 and 54. So the 2 subgroups where the number of diagnoses have actually plateaued are, those who are between the ages of 25 and 35, and then those who are 55 and older. Now, why is any of this important? Well, as you can imagine, each age group has their own set of developmental needs, psychosocial needs, physical, factors. So from a prevention perspective, we actually have to have different approaches, different messaging for each group, right? Long gone are the days where we have this cookie cutter approach that will work for everyone. So when we say it's National HIV/AIDS and Aging Awareness Day, this is actually a misnomer, because the day is actually not about all the different age groups, and it's not even about overall aging, right? I mean, all of us are actually technically aging every day that we're alive. We're indeed aging. But again, that's not what this day is about. Public health groups, medical groups, we often use the term aging to really specifically hone in on older populations, which is, depending on the source, either over the age of 50 or over the age of 55. So with that in mind, when we say it's National HIV/AIDS and Aging Awareness Day, what we're really talking about is bringing attention to the people who are living with HIV over the age of 50. And because of the success, though, of HIV meds, people really have been able to live very long and healthy lives. In fact, we actually have data that shows that people with HIV are now starting to be more likely to die of non-HIV related causes because of, like I said, the life-saving meds that they're on that really suppresses and keeps their viral loads very low, which means that this infectious disease is actually operating as a chronic disease for many people, like I said, that are on HIV meds. And it also explains why half of all the people with HIV in this country are actually over the age of 50. So this is actually good news, right? Because, this was certainly not the case early on in the HIV, epidemic here or pandemic worldwide. So speaking of awareness, did you even know that people living with HIV over the age of 55 in particular are actually faring better than any other age group of people living with HIV? Right? So as you can see on this infographic, for every 100 people living with HIV, overall, 86 of them will even know of their HIV status or diagnosis, as is noted on the slide. But if you hone in on those who are over 55, 95 of 100 actually know their status. And then you can see the other successful outcomes, right? 71 versus 65 will receive care, 57 versus 50 will stay in care, and 64 versus 56 will have low viral loads. And still, it's not 100 out of 100, right? So even though that is some success, we can, applaud the progress we've made, there's still work to be done, right? So what I want to do with the time that remains is just share some tips that can be found in the reference guides that HRSA's Ryan White program published back in November of 2020 on putting together the best care team for people living with HIV. And then the other one is on incorporating new elements of care. And both of these reference guides are for clinicians, and they focus specifically on working with older people living with HIV. So that first recommendation, it may seem like, okay, this is common sense, but we have to constantly remind ourselves around the diversity, because we have a tendency of grouping people by population, and then kind of really treating them just by this particular disease diagnosis, not realizing there's so much variety within one particular population, right? Lots of diversity, whether we're talking about a range of social identities, but we're also talking about age diversity, right? Everyone over 50 or over 55 don't have the same needs. Just imagine, a person in their 50s is going to have different health and psychosocial needs from somebody in their 60s or someone in their 70s. And so, while those over 65 really do become more eligible for things like Medicare and just other services, That's not the case for those between the ages of 50 and 64, because again, those services are not designed for that age group, even though those who are 50 to 64 are considered a part of that population, right? So another form of diversity is how long has this person been living with HIV, right? Someone who was just diagnosed last year, the last 2 or 3 years, very well may respond differently than someone who's been living with HIV for over 20 or 30 years, right? And this also includes, just physical responses, because we know with any medication, there's going to be long-term effects. So yes, there are some long-term effects of antiretroviral treatment, or ART, the treatments for HIV. But that also means that, not just a physical response to meds, but also the mental response for having HIV, and how that actually shapes your identity as someone living with HIV, how it shapes your lifestyle, it shapes your choices, right? So again, there are going to be those nuanced differences. And so specifically for those who are just receiving HIV diagnosis over 50, they not only have to learn about HIV, right? And what this could, means for their own health, but they also have to begin talking about this with their entire medical team and hopefully with their loved ones. And so we already know the healthcare system is unnecessarily complicated. So navigating the HIV related system of care on top of that, and then all of the available support services, really can present its own set of challenges and, a learning curve, especially depending on where you are in the US, right? Because we know obviously from like state and local policies are a bit different. So, the next recommendation is to recognize the psychosocial needs of patients, right? There's this tendency to only think of, like I said before, HIV in the physical or biological sense. But living with HIV also affects your mental self, your emotional self, your social self, right? So this is why HRSA actually has been collecting evidence that older adults living with HIV, they often experience social isolation and loneliness, or even just a lack of social support, which, by the way, can have nothing to do with, having HIV, but because of your age, maybe you were already used to, living alone. And so, then now that gets kind of exacerbated. And so one related to their age, but then another related to having HIV. So I wanted to kind of just turn to some of these one by one so we can get a feel for what exactly we mean by psychosocial. So if we were to look at a person's quality of life, right? As someone gets older, they're, more likely to experience just a range of health challenges. That's just an inevitable fact. And so, it's just associated with getting older, right? Sometimes that may include chronic conditions like heart disease, which is, it's rampant around the world. It's actually the #1 cause of death around the world. So yes, like chronic diseases like heart disease, kidney disease, diabetes, but physical chronic conditions are actually linked with mental chronic conditions. Mental chronic conditions, yes. Ones like depression, like anxiety. Why? What's the association? So it's not a causal link, but there is an association, so just think about, again, shifting your lifestyle, what you eat, or potentially how you function, and then add in the aging process that very well may result in you having to rely on others more than you've had in the past to help you with kind of everyday functions. Again, going back, like I said before, especially if you live alone, again, you could have always lived alone, or you can have now with, an empty nest because a spouse either has left, has transitioned, or you have grown children, things like that, right? So you just basically start to feel lonely and isolated, and that's common actually. And we know it was actually even more heightened in this COVID era that we're living in. So, we all really do need to talk to our healthcare teams about our mental health status, because this affects our physical health, right? With or without HIV. So some older adults also may have mobility challenges, whether that's, outfitting where they live to accommodate how they're getting around, or actually just feeling impaired by pain. And, chronic pain is also real, or some other kind of diagnosis or disability, but also just getting around outside of your home too, right? Getting from, one place to the next. And even as digital as the world is getting, especially like I said, in this COVID era, there still does remain challenges to technology, right? This can be everything from having, constant, strong broadband access to just actually knowing how to use a device or for the purposes that you need it. So for all of these reasons and more, service providers and clinicians really do need to create welcoming environments where older people feel comfortable asking for help and they actually get the resources and the services that they need. No matter if it's groceries, again, Wi-Fi, transportation, or just someone to garden with, right? So if these types of concerns are not addressed for people living with HIV, it very well, is actually well documented that it does affect their likelihood to get in care, stay in care, get treatment, or stay on treatment. So as we know, HIV affects the immune system, right? So depending on, the viral load, some people living with HIV indeed are immunocompromised and at a higher risk for COVID. And as we all saw, COVID made very clear the existing disparities that socially disadvantaged populations face in housing and transportation and food access and economic security. But the good thing is that, more and more clinicians are, started offering telehealth, and many still do, to help kind of cut down on the barriers to getting into a medical home. But this is still very imperfect because everything can't be done virtually, right? And again, like I said, the digital divides make telehealth, not a viable option for everyone. And it also is no surprise that, the US is experiencing a shortage in healthcare workforce, and this has been the case for a while. So this is actually affecting everyone, including older people and including older people who are living with HIV, right? So PCPs are just not trained, nor, just to be honest, do they actually have the capacity, like the time capacity, or even the resource or infrastructure to really meet the dynamic needs of older patients. So this is why geriatricians are a subspecialty. But as with any specialty, these types of clinicians are not widely accessible in all crevices or pockets of the US, let alone the actual other specialists that you need as you age, right? A cardiologist, an endocrinologist, a rheumatologist. So, this is why we have to talk about ageism, because we know ageism is real, right? It really does explain why everyone, may not necessarily feel the same way about the concept of what it means to get older. And so again, the set of guidelines that that HRSA's Ryan White office came up with, it really does help clinicians think about how do you talk to patients who may not think of themselves as old, right? Who may not want to enroll in a program or access a service designed for old people, especially again, if that patient doesn't feel old or they don't look old, but you have their chronological age on the chart and you're saying like, oh, this is for you. So there really needs to be some consideration to attitudes around aging. And this is not just for people living with HIV, but just also for clinicians who care for them, right? Because, because sometimes because of ageism, right, clinicians may make assumptions that, oh, they're not having sex or they're not exposed to any of the 5 fluids that transmit HIV. So we can gloss over that conversation, not bring it up. And it also is worth noting that some patients over 50 who have HIV don't know because they actually do have signs and symptoms of HIV, but they're mistaking those signs, right? Whether that's weight loss or swollen glands or low energy, short-term memory loss. They're having some of those things, but they're associating that with some other condition that they have, or just related to like, oh, I'm getting older, right? So this is why we have to stress even more to clinicians, don't rule out HIV or the types of questions that you would ask of, any other patient. So, what age-related stigma is not the only concern, right? Clearly, there also still exists HIV stigma. And this stigma, really does prevent folks from initiating conversations about HIV with their PCP, with their geriatrician, with anyone on the medical team, let alone getting tested for HIV, getting on PrEP if you're eligible, talking about, HIV testing or your status with your partners, with your family, right? And again, like I said, I know in a minute, me and I are going to talk about, well, where some of the stigma even come from, how does it really impact older people and how they kind of think about HIV and their risk for it. So, because of the just pervasive nature of HIV stigma. You know, there really is 13%, this is an estimate from the CDC, of people who just don't know their HIV status. And you know what that means when you have 13% of the population that does not know they actually do have HIV, that means that they're obviously not benefiting from life-saving treatments that we just talked about, that we have record and documented that actually will increase your likelihood of living long, right? And that also means that they can still transmit HIV to other people. Again, HIV stigma is why people are not getting tested, or it also explains why some people may feel offended or even targeted if a clinician were to ask them about HIV or getting an HIV test. And that's actually one of the things I want to talk about with the research and the project that I'm leading. So speaking of awareness campaigns, I really like this one the CDC has on how to frame conversations on HIV as a way to come against HIV stigma. And I'm happy to talk about that when we get into the discussion about just moving away from very kind of problematic and stigmatizing language. So I'm going to end here with the call to action, okay? So again, before we transition into that discussion, I just want to invite everyone, if you're not already, doing these things, right? To talk, to test, to learn, and to tweet, okay? So talk. We have to talk to our partners, but we also have to talk to our clinicians, right? Whatever healthcare, practitioner we're seeing, we need to talk about the behaviors that we're engaged in that are either protecting us from HIV or potentially exposing us to HIV. And if we're sexually active, we and our partners need to get tested every 3 months. And so for those of us who do HIV work, we need to learn more about older populations, right? What are their unique, distinct, and nuanced needs? How can we prioritize and address those needs in our efforts so that they don't become an overlooked population? And whatever you are doing though, right? Whether, that's interpersonally, whether that's in your networks, whether that's through your work, share that, post that online, use hashtag HIV and aging, use hashtag NHAAD, which is National HIV AIDS Awareness Day. And by doing that, you're joining in on the nationwide online discussions right now that we're having on this important observance leading up to September 18th, okay? So I do welcome you to keep in touch. You can email me here, Miranda, my first name, at gwu.edu. You can follow me. But what I want to do now is I want us to get into some of the questions. And a little later, I'll pull back up this slide, which is when we do talk about, the research and the program that I'm leading. This is a QR code where you can just put your phone up and it'll take you directly to the website so you can learn more. But I'll just take this down for now so we can have a conversation.
Dr. Ward, that was stellar, quite a stellar presentation. Thank you so very much for all of that information. Before we go on, 2 things. One housekeeping reminder, for any questions you have, please put the questions in the Q&A box just at the bottom of the screen. Any comments, please put the comments in the chat. We want to make sure that we're going to get to the questions, and we want to also make sure that we're keeping, being mindful of the other information people are bringing to us. Dr. Ward, in the beginning of your presentation, you did something that I feel is so significant. I would love for you to speak a bit more about it. You were very clear in terms of your disclosures that you are a person who's not living with HIV/AIDS, right? With HIV or with AIDS. Why, can you just go back and tell us why is that important for you to do that, particularly given the work that you do, and what does that mean for other people who might be interested in working within this field and they themselves are also not living with HIV or with AIDS?
Yeah, okay. So I think it's just really important for me to make very clear that there's a variety of expertise, right? And so, you know what, I can't speak to what it is like to live day in and day out with an HIV diagnosis, managing that, again, like I said, physically, mentally, emotionally. So that's not my reality, right? So I can't speak to that reality, nor should I attempt to. And I think that's really important that practitioners actually make that very clear and invite into the space, into the room, into the discussion, those who do have that lived experience and recognize that experience as a form of expertise that is valued and necessary to move, the pendulum towards equity. And so that's why I wanted to be very clear that, I don't have that, nor I'm going to attempt to, be able to speak on behalf of those that are managing HIV. But again, the expertise that I can offer is this, right? So what that does for me is it allows for me to say, you know what, I may be at the limits of my knowledge here. And this is where you come in. It invites a conversation. Like I said, I am here to learn. This is an environment of learners, myself included.
For sure. And so my follow-up question for you then, Dr. Ward, is, you gave us an overview of the significance of the celebration on Sunday in terms of National HIV/AIDS and Aging Day. Tell us a bit more about, what's the significance of that at the, from the intersectional lens.
Yeah, so, I actually teach, remember, so when early on where Dr. Keys introduced me, she shared how I teach undergrads and also I do some faculty development at GW. So when I have discussions with my students about health disparities, I make very clear that when we're having a conversation about health disparities, what we are not talking about are the naturally occurring health differences, right? There are some differences in health that are to be expected because of genetic, differences, neurodiversity, and just like a range of, inevitable forms of difference. When we talk about health disparities, what we're talking about are the unnecessary, avoidable, and unfair differences in health. And so there's no biological explanation for those. They are 100% social. And so now, we move away from talking about individual people's health, and now we're talking about population health, right? Because health disparities don't exist in people, they exist across entire populations. They're patterned, they're trends, and they're not happenstance. You literally can tag them to larger macro, social issues and social ills. So I think I will say that when, we have these national observances, the reason for that is because we're pinpointing that a disparity exists here. Again, an unfair, unnatural one. And we have to, really pinpoint the source of those inequities. And so by doing that, we're really honing in on what are the forms of social disadvantage. If you think about it, all health disparities are targeting and only impact the same groups. They're all experience social disadvantage. So the population of interest to us for September 18th is populations that, experience social disadvantage by their age, right? So there's a social disadvantage. I'm going to be very clear. There's nothing inherently disadvantaged or deficit or, lacking with getting older. Again, like I said, that's a prize. Like, that means we're alive, right? So I don't want to, stigmatize the idea of getting older, but socially it becomes a form of disadvantage because now you're, more and more dependent on others. And when you become and there's a range of groups that are dependent on others, those who are children, those who are immunocompromised, which is another, like people who live with HIV can very well be immunocompromised. That serves as a form of dependence, right? Not being health literate, like all the groups, and then being older. These are that source of dependence, someone else determining, where you live, what you eat, if you seek care, all of the things, right? So that becomes a source of a disadvantage and therefore vulnerability to the poor health outcome, the unfair one. And so the other thing is that, HIV actually back in 2008 was classified by the ADA as a disability, not because it, for those who, again, we know depending on, it's going to be very different depending on where you are in the trajectory of your, prognosis, and, where you are in your treatment and where your viral load is. But for some, they very well may have limited functionality and ability. And so therefore would benefit from have accommodations for disability, especially the legal protections that come with ADA and, and that legislation for not discriminating against, those who have disabilities. So again, we know disability is also a source of social disadvantage. So again, this particular day focusing on National HIV/AIDS and aging awareness really allows for it to come full circle for, kind of naming the disparity for what it is and removing the stigma associated with being part of the very groups that, are disadvantaged. You're frozen on my end. Are you? Is it just me?
You could not, what's that?
I'm sorry, it was frozen a bit on my end. But
Oh, okay. Is it all, we're all good now?
Yeah,
There we
we're all
go.
good now. Okay.
Thank you for that. You know, so you were just talking, disparity is a natural difference. It occurs in terms of differences across various health outcomes, but in terms of the unavoidable, excuse me, and they tend to be unavoidable, but in terms of actual avoidable differences that matter and that come about as a result of policy, as a result of providership, as a result of any sort of structurally related contribution, that's essentially what you're getting at. That's why having this day is of major significance, because it does bring additional attention. You know, I want to add an additional layer, because I talked about intersectionality, then I want to get to the registering questions. Actually, this is one of the registering questions. When you add on top of HIV, living with HIV or living with AIDS, when you add on top of that aging, and then add on top of that sexual orientation, particularly for members who are within the LGBTQ plus continuum, you know, what does that mean in terms of really, one, communicating the messages in terms of their significant but also unique needs to providers, and two, when it comes to mental health, especially in the wake of COVID, what do we need to be mindful of?
Yeah, so you know what, this is the perfect time to kind of get into some of the work that I do. So I appreciate you sharing that around, you know what, it's so important that for every work that we do, not, you know, no matter what the work is, to take an intersectional lens, right? Because none of us have just one sole identity, right? So I think that when we talk about, like, so for example, I'm gonna introduce a project that I'm working on, then that will allow for me to kind of come back to, you know, why we designed the project in the way we did with this intersectional lens. So yes, you know, we are still in a pandemic, right? A triple pandemic at that, right? We got sanctioned violence, racism, and we have COVID. When we just think about COVID right now, there's just been, you know, a lot of attention has been, you know, rightfully paid to COVID policy, allocating resources, COVID, the science, you know, to have the research and the vaccine and the like. But it's, you know, to be frank, it's been at the expense of HIV. And the thing is that we really can't afford to, you know, put all of our attention solely on COVID, because it's the same patient populations that are disproportionately impacted by both, right? That being Black and Brown and LGBTQIA identified folks. So those are, you know, again, over time we see those are the populations that have the biggest burden of, you know, poor health outcomes in general, especially as it relates to HIV and COVID, because of, like we said, the structural reasons, not because anything about, you know, having these identities. And so for those reasons, you know, I've designed a research-informed educational intervention that I call 2-in-1. And the reason why we call it 2-in-1 is because we're saying, you know what, primary care practitioners literally should be routinizing, making it part of the standard of care to ask all patients about, you know, and about HIV. Like we call that screen for HIV, right? So if you think about it, we have a model for this because we've been doing it for COVID, right? Like literally, if you call a PCP, you want to schedule a doctor's appointment, you already are met with a set of questions about your exposure and what you're doing, right? And that'll determine your next move. So we know it's possible to like literally kind of roll this out for HIV. Obviously, it's not going to be in the same way because, you know, obviously one is infectious, you know, one is like airborne and more contagious than HIV, but nonetheless, you know, there's precedence for that. And not to mention a lot of federally qualified health centers actually have already, you know, since they have Ryan White Fund, they actually been able to routinize it. And in DC in particular, since we did have an epidemic not too long ago in DC, you know, DC has become a model city and we've actually routinized HIV testing in all of the emergency departments. So the point is there's precedent for it, but right now it doesn't exist. So the CDC guidelines back in 2006, you know, state that, okay, PCPs only need to ask at least one time, you know, anybody over the age of 13 to 64 at one point in their life, ask them about, you know, an HIV test. And that's not how HIV risk work. Right. So what we're suggesting through this, we're making the policy case for, what we need to ask all patients so that Black, Brown, and LGBTQIA patients don't feel targeted, because there's already a profile and there's very well documented clinician bias. So, we don't want to contribute to that. So we're saying, no, across the board, everyone should be posed these questions, and depending on their response, then you will immediately screen for PrEP to see if they would be a good candidate for that. You will give them the HIV test if they need it, because if they don't have the risk, then you need to do the test, right? So again, it's almost kind of like a if-then kind of logic. But also we want to couple that with screening for the COVID vaccine. So right now, screening for COVID is happening out, like, again, you call and it's like, oh, don't come here if you have symptoms, like go get tested, do a PCR, do a home test. Okay, that's fine. It's not even happening in the primary care environment. It's happening out in the community or in home. But what we're saying is screen for the vaccine. So when people are coming in, not, for non-COVID related reasons, or maybe for COVID symptoms, then you can ask them if they have the vaccine, if they have the booster, and we realize rightful reasons that, from, historical research abuse and, scientific racism, why some, these very same, patient populations may not want to actually have a vaccine or have a booster. But again, it's incumbent on clinicians to provide that education, right? And provide the opportunity. So in the event that you are able to say, you know what, I got it, and this is why I got it, right? Again, personalize it. And then especially, we have, some patient populations that are more likely to feel connected and trusted and feel like rapport with providers that look like them. And so those providers can actually say, and I got, the vaccination, and I got the booster, and I did for my family, and I did it for my grandmama and whoever, right? So, you know what, maybe you can try it, and then just like meet patients where they are without trying to overburden them or shame them. But ultimately, these conversations need to be had. And so we're saying that when working with LGBTQIA and and Black and Brown patients, the messaging has to be culturally responsive. So even though you're going to be screening everybody, there's a specific way you have to talk to these groups because of the things we just talked about, right? There, again, the overarching historical, intergenerational, trauma, again, that's affected our mental health, that's affect that, the daily affronts on our identities and who we are. I'm sorry about that, that's my dog. And then we both got a lot going on in the background.
All kinds of background things today.
Exactly.
It's Friday.
It really is, right? So ultimately, that's why we designed the model, like this dual screening kind of approach, with the identities of patient populations in mind. So I appreciate that question.
I appreciate that breakdown. And I'd be remiss if I didn't acknowledge that we have a number of participants today who are international, and they're either from outside of the United States, or they themselves right now are tuning in from other countries to this critical conversation. When we're talking about, because to your point about culturally responsive, culturally competent, culturally compassionate care, it's the Black and Brown communities that have been socialized in the United States, but then there's a whole nother level when talking about HIV/AIDS, when you're talking about persons who are not originally from the US, but now call the US home, or are seeking care models that are US based. One of the registrants wanted to, ask a question in terms of, how should providers work on getting over stigma, or persons who work with providers help them get over stigma, if a part of the stigma associated with HIV/AIDS is culturally based itself. It's superstition, for instance. This is one of the registrants' questions.
Yeah, I mean, you're right. Stigma, and that's the reason, that's like our biggest challenge actually is stigma, right? When people don't know or understand something, there's room for fear to shape what they hear, to shape what they believe, to shape what they share, to shape how they respond, right? And we saw this play out. So let's talk about the US specifically. We saw this play out back in 1981 when we learned of the very first HIV case in the country. And so at the time, the patients that actually were getting HIV were gay men, right? So which is why the original clinical diagnosis was GRID, gay-related immune disease. And that name in of itself, which is why we say language matters, fueled stigma, discrimination, and hate. And so what it did was it started to shame and demonize people because there's a taboo going back to cultural, right? There's a cultural and social taboo related to sex. And then of course, it was connected to sexuality. And then connected to injection drug use, right? And then these will happen to be the actual behaviors associated with how you come in contact with one of those 5 fluids, right? So that is literally, then the judgment was placed on the people, and, and then we moved away from, thinking about the actual fluids, and then it just become rampant, and then, polarized, because, then it's all, in a political climate. So again, this just lives on today. And it's why someone would use stigmatized and problematic language of the past of like, oh, you can catch AIDS, or if I hug you, will I get it? Like all of those things really come from not understanding HIV. And again, it has its roots from how it was first introduced. And we're still kind of, trying to combat that. So, bringing it full circle is like, well, what can clinicians do when, you have these, again, cultural differences, social, faith-based differences that have fueled this misinformation or conspiracy theories? All we can do is provide, meet patients where they are and share, information, right? Like, again, like if you think about here in the US, in addition to our aim to eliminate health disparities, that's part of our nation's health goals, Healthy People 2030 goals, is to eliminate health disparities. And we want to achieve health equity. But another thing we want to do is attain health literacy. And so if people don't know where to get information, because again, when this digital age that we live in, where it's like information overload, and people get a lot of their information on social media, right? And it's kind of like, oh, somebody, put in a YouTube documentary together and I believe that. It's like, wait, so understanding, okay, credible, credible sites and, sources of information, and then, just, and patient education. So again, we see the same thing happened with COVID, right? In the way that it was introduced in a way that was very, just discriminatory to, Asian Americans and just like Asian people around the world with like how it was named. And then, and then blamed, and then same thing with monkeypox, and oh, it comes from monkeys just like they was like, no, change the name. Like all of the, literally with each of these infectious diseases, it literally, they've become impacted by stigma. And then that is going to be why someone would be less inclined to get a vaccination, to want to talk about it, to be, have very open, frank conversations with family, with, providers. And so, so I say, it definitely has to just be meeting patients where they are without kind of passing judgment, because again, we all are part of socialization processes.
Again, well said. I mean, this is one of those conversations that people are going to come back to over and over again because you've unpacked so much. There are questions in the Q&A box asking you to reiterate the relationship between HIV, aging, and living in isolation. But because of our time, I do want to make sure that people can just go back to that within the conversation. I'm going to pick up this little one at some point. But if you do have time at the end of our conversation to reiterate the relationship, then we can do that. What I do want you to potentially talk about right now, Dr. Warren, is, when it comes to people who are living with HIV, but they themselves are not over the age of 50, particularly Black women, how is it that providers, and how is it that you work with people, predominantly people who are in the student pipeline, to be mindful of that? Because frankly, we wouldn't be having a conversation about HIV and aging more than 30 years ago. It just would not have been the case, right? So the fact that we are having an aging conversation on top of HIV/AIDS, that says a lot in terms of how the science has moved forward, but it doesn't always necessarily relate to how socially we've moved forward with being able to be mindful, not even just within the healthcare system, about how we're engaging and being mindful of lived experiences. So I just gave you a lot right there, but I know you can unpack that.
Okay, so let me just briefly say to the first question that when I made the connection between HIV and isolation and mental health, I wasn't saying that HIV leads to those things. I'm saying that there's a relationship between them. So just let's table HIV for a moment and let's just talk about aging and being older. Again, we see and we have evidence that as people age, they are experiencing loneliness and isolation. And for the reasons that I mentioned before with, okay, depending on how old you are, your spouse, you know, if you have a spouse or your partner may have, again, transitioned, whether they moved on with their life or whether they, you know, passed away. So you're living alone and you feel alone, right? Or you know, for other reasons, you don't live with other people, or you have children, but they're all grown and they have since moved on, right? So like that, those, and then, or you're actually now in a nursing home, or just, again, you're separated from the kind of the family that you're used to, or the loved ones that you're used to. So in that age group, there's loneliness and isolation happening. What I'm saying is that becomes exacerbated with older adults who now also are managing HIV. So that's what that's the relationship that I was describing, and the set of guidelines that are being offered to clinicians on how to have conversations around mental health as they're talking about the physical health, you know, the physical signs and physical aspects of living with HIV. And so to the second, you know, kind of point or comment around, you're right, the science, you know, has certainly progressed. Absolutely. There's evidence that, wow, the science works, HIV meds work, because look, people can live. But again, what we're not talking about can people live? Now we're talking about quality of life. You're living with HIV until you're, you know, 60, 70 years old. But what is the quality of life if at every turn you're discriminated against? Right? At every turn, you know, you are, you know, experiencing a range of unnecessary, unfair barriers, right? Socially and, you know, and geographically. And so we're talking about the quality of life, and those are the ones where the science can't address that. We, you know, as social systems, policy, you know, advocates, you know, grassroots, you know, organizers have to address that, right? And we have to change ideologies so that as people access services in the community, as people, you know, are in, you know, the education system, or they're in the criminal legal system, as they're in the healthcare system, that they're not being treated inhumanely, right? That they're not having your human rights violated. So socially, we have a long ways to go. And that's not just with HIV, that's also with COVID, it's also with a range of other infectious diseases.
To your point about quality of life, there was a woman who mentioned, oh, he is not happy with me, but he will be soon. Nikki's are soon coming. Oh, thank you so much for your patience.
Right.
I want to get back to one of the questions from the audience about, you know, aging with HIV looks like.
I don't know why it's going in and out for me, but
long term. These don't necessarily, you know, really work to. Oh, he's not happy. Hold on, just a
no, it's okay. You know what? What I can do, Dr. King, is that I can. Yeah, I'll go ahead and check the chat. Okay, so can people hear me? Because it was kind of going in and out, and a couple people added in the chat that it was going out. Okay, perfect. Okay. So some of the questions are about the impact of the drug. So yes, let me start back with that. So even though, yes, the science has certainly progressed, you know, yeah, I mean, the drugs themselves, the antiretroviral treatment is, there are long-term effects, right? And this is with any treatment, there's going to be effects. So there is going to be a level of toxicity and, you know, impact on the functioning of your body and organs. And so that's just one of the things that happens when you introduce, you know, like when we talk about toxins, we often think about pollutants in the air. We think about, you know, you know, just like poisons, but like toxins also do include drugs. You know, not just, you know, illicit drugs, but like actual drugs that we use day in and day out to manage, conditions. And so that's just one of the, I guess, downsides of, you know, of the treatment and like the, you know, what it's doing to attempt to keep the viral load at bay. And so you're right, for those of you who've weighed in on the chat and then the Q&A about, the long-term effects of art is just no joke, right? Like it really is presenting a set of its own problems. So it's kind of like, that's why you have to have those discussions with your medical team, like, okay, be on the HIV meds along with whatever else is going on, and what that's going to look like for you, or versus if you not be on the HIV meds, like what that's going to look like. So it's kind of like, it's a cost benefit analysis that has to be determined, right? And so again, HIV is very well funded as far as HIV meds are concerned, and so they're trying to address and adjust the those effects, but that's just one of the drawbacks right now. That's just one of the limits of science. And so even though we've progressed much, yes, those drugs do take a toll. Let's see, were there any other questions? Let's see, where do we fall? It says, I think you already answered this. She already answered that question. Someone had a question about taking ART, the viral load. And okay, so some of the questions, like some of the very specific clinical questions about, if I take art, like what's that going to mean for my viral load? Will I be at 0? Will I be at this number? Those are very specific clinician-based questions. I'm not a clinician, so I'm not going to attempt to say, okay, yes, it will eliminate it, it will reduce it. I can say that you will have that conversation with a clinician so they can say what's possible for you. But we do, again, have evidence that, art is very effective. But obviously you have to have case-by-case scenarios depending on your whole health profile. So I feel like it's important with, this is what aging looks like, aging with HIV. Okay, I think, did I answer all the questions? Because I think we already
did. I wanted to actually go back to something you just said here, Dr. Ward. When so we talk provider care, we talk stigma. What is the role in terms of research, and how is it, especially because you're engaging students all the time, what is it that you're trying to impart to them in terms of how they even structure their research to be mindful about all the things that we discussed today?
Yeah, so I'm so glad that you posed this question, and this is the perfect way to just kind of bring everything full circle in the 3 minutes that remain. So basically, it literally is the way what I talked about early on. It's like when you don't have the experience of people who actually are, in the clinical environment, then, we can look at the literature, because that's what any, good researcher is going to do, right? The very first thing we're going to do is, what does the literature say? Because you want to see, are there gaps in what we don't know, right? Because the literature is like a body of knowledge. So you want to say, okay, what do we know, or what do we still want to know? But the thing is that the literature is still imperfect, because if you think about, the idea of like colonized knowledge, is the idea that this elite group of academics and intellectuals has said, this is what's important to know. That's not everything that's important to know, which is why you have to design your research to be full circle. Okay, yeah, I'm going to look at the academic literature, but I'm also going to talk to real people that are, like in our case, the actual PCPs that are working directly with Black and Brown patients and LGBT patients, and actually patients who identify as a racial, sexual, gender, ethnic minority, and say, what are the barriers and facilitators to your care? And in combination with those counter stories and, and these like stories and counter stories in the literature, we'll have like a fuller picture of like, this is what's happening, right? And so I think it's so important that we design our research to tell full narratives and not, contribute to, the disparaging ways that often marginalize, populations and voices, how they get marginalized in and by research is the point that I want to make. So I'm just going to pull up the flyer one last time, just in case.
Pull that up.
Okay, yeah. So just in case anyone is interested in.
As you're pulling that up, Dr. Ward, I just want to make clear for especially those academicians who are on the call today.
Yeah,
I know it can be very difficult to push the envelope in terms of what standard research need look like, because it's not always going to look like you said, it cannot always look like, Dr. Ward, like you said, the colonized knowledge, right? Especially when you're talking about populations that have unique care needs, are going to be with us and a part of our lives and our families for a long time, the science needs to reflect the changes.
It really does.
Thank
It
you.
really does. So basically, we want to hear from you. All of those who, who are patients on this call, please, type in 2in1.smhs.gw.edu or pull up your phone if you have one and go to and scan this. It'll take you directly to the website and tell us your stories. Like, what is it like being, talking to a PCP about, answering questions about HIV or COVID, right? And then if you're a PCP, we want to hear from you too. What is it like having that responsibility, and you may feel discomfort, or you don't have the time, or whatever it is? We want to hear from both of you. For 60 minutes of your time in a focus group that's virtual, you will get a $30 Amazon gift card. And we're actively recruiting right now.
Go, go, go. We'll even put the, I'll ask Keiko to put the website in the chat.
Please, that's awesome. Thank you.
Yeah, for sure. And we're 1 minute over. I just want to say thank you once again to Dr. Miranda Ward. Amazing, not even just researcher and educator, but advocate, and someone who's very clear about her positions and where she stands in her lived experience, but then also what she's purposed her life to lead. And so I want to thank you all for your energy, for your questions, for your comments, for your vulnerabilities. And also for your patience as we live in the new world of remote working, and we've got little ones, we've got dogs. It's all just a matter of, I won't even say balance. We're very clear about work needing to get done, and having those who are going to eventually take the baton, sometimes literally sitting at the feet. So thank you all for your patience. Dr. Ward, any final closing words before we take it away?
No, I think you summed it up well. I just want to thank everyone for being here, for their time, and I look forward to continuing this discussion offline.
Dr. Ward is continuously doing work with the National Minority Equality Forum. Thank you once again to NMQF. Thank you to you all. I'm Mia Keys, and I look forward to joining you all very soon in future webinars. Have a great day. Stay safe.
Have a good day and your weekend. Bye.